Hello, I'm Jennifer Summersgill and I am an MRI medical physicist at NHS Tayside. In 2020, our centre started using the MAGSEED breast marker by endomagnetics as a less invasive option than previous methods such as localization wires. The marker guides surgeons to the breast cancer or node and is detected using its magnetic trace and the CentiMag probe. Our breast radiologists asked us to determine how a breast MRI scan would be impacted if a patient had one of these markers in situ. The marker documentation states it is 5 mm long, made of stainless steel, and it is MR conditional with a maximum artifact of 4.1 cm. Initial testing was performed with an ACR phantom, which was scanned using our clinical breast protocol. This is a cylindrical phantom with various fixtures inside to see effects such as signal loss and distortion. This testing showed the artifact was 4.1 cm for spin echo sequences, but considerably greater for gradient echo sequences. To see the effect of fat suppression, a healthy volunteer was scanned with the marker placed on the skin surface of the right breast at the axilla. Scanning was again performed using our clinical breast protocol without contrast. The results agreed with our phantom testing in that the artifact was 4.1 cm for spin echo and greater for gradient echo. However, in the two sequences that involve fat suppression using STIR, the artifact increased up to 9.5 cm. In addition to MRI testing, it was decided that since the marker will be removed during surgery, a patient is more likely to be referred for an emergency CT than a routine MRI whilst the marker is in situ. CT testing was performed with a Kyoto anthropomorphic chest phantom. The marker was positioned inside the chest cavity and scanned using both filtered back projection and 50% iterative reconstruction. This is because two of our older scanners can only perform filtered back projection. There was no metal artifact on either reconstruction method. In summary, our MRI testing has shown the MAGSEED marker has an artifact consistent with the implant documentation for spin echo imaging. For gradient echo, the diameter is larger, and the presence of the marker causes fat suppression to be unsuccessful, increasing the artifact to 9.5 cm. A patient with this marker in situ would not be able to have a fully diagnostic breast MRI exam until the marker was removed. If the scanning region of interest is more than 10 cm from the marker, then the scan may still be justified. A CT scan will not be impacted by the presence of the marker. Thank you very much for listening, and I hope you enjoy my poster.